Well, hey, welcome to Caring Essentials channel and brand new series entitled Transformative Nursing in the NICU, Trauma-Informed Age-Appropriate Care, second edition. My name is Mary Coughlin. I'm a neonatal nurse practitioner by training, and I am the president and founder of Caring Essentials Collaborative. And my strategy is to, really just get the word out there, share as much information as I can about this concept and the paradigm of trauma-informed care for critically ill babies and young children and their families, of course, in a healthcare setting. And so what I thought to kind of like break the ice for me and possibly for you as well, I thought I would just kind of like take you through the book. And so each day from Monday through Friday, I'm going to present these little sessions. Each day I'm going to do a chapter in the book. Some of the chapters I might actually break up into more segments because the content is pretty dense, but that's my plan. That's my idea. So we're going to kick this off on Monday, January 3rd, and I'm going to introduce this concept of transformative nursing in the NICU with the opening chapter that really kind of sets the stage for why this is so relevant, not just biologically, psychologically, but sociologically and globally as well. Section 1 of the book really is kind of an introduction to this concept of quality healthcare. And so I start out in chapter 1 addressing just that. What is quality healthcare? And the book came out in January of 2021. And as you can imagine, there's been a lot of additional research and information that's really talked about this idea of quality healthcare. So first, just kind of like, let's pick apart the words, okay? What does quality mean? High quality, a good quality. It's how we judge something, right? It's how we judge something in meeting specific metrics, specific expectations. And what we find with regard to quality healthcare, there's a variety of different ways that folks look at this. From the Institute for Healthcare Improvement to the Institute of Medicine, who actually was the first organization to lay down 6 aims, if you will, of quality healthcare. And so those aims, I don't want to mess them up, but it was around safety. It was around patient-centeredness. It was around timeliness, efficiency. Oh my gosh, I'm totally forgetting all of the different elements of this, but these 6 aims really looked at kind of the tangible dimensions of healthcare, if you will. And they kind of give you this caveat definition. This is from the Institute of Medicine, and it's a definition from 2001 that was kind of crafted as a consequence of their initial publications looking at the quality chasm in healthcare here specifically in the United States. And that quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So, so great, that sounds really good and everything, but where the challenge comes in is where when people are really trying to measure that, they're trying to quantify it, not just people, kind of at healthcare organizational level, but even, at the government level and certainly payers. And payers play a big part in how healthcare systems are measured, are evaluated, are assessed and reimbursed, all of that kind of stuff. And I didn't really get into too much of this when I was talking about it in the chapter, but in preparation for this series that I'm doing, I did a little bit of extra digging. And of course, a lot of the literature that I'm coming across is colored by the expose, if you will, of our healthcare system as a consequence of the COVID-19 pandemic. Some of the information is actually on par with pre-COVID information, particularly when we look at the quality evaluation or the quality analyses that have been done by the Commonwealth Fund. I don't know if you guys are familiar with this organization, but it's a really cool organization that compares healthcare indicators with around the globe. And so we, as a country, get compared with other like countries, and then, you know, kind of cascades down to all of the countries on the planet and how they meet these different quality indicators. Well, consistently since the beginning of the Commonwealth's inception and attention to evaluating U.S. healthcare and our quality and how we meet, how we shape up to other high or wealthy, I guess that's what they call them, wealthy countries, we don't do so good. And just recently, this other organization that does health analyses and tracks health systems, they put together this really cool quality of care white paper talking about the state of the US health system and as a 2020 update. And we continue to fall, you know, way behind other industrialized, wealthy economies and countries across very key critical indicators for quality. And these key critical indicators for quality include indicators around the life expectancy, morbidity and mortality, the burden of disease, premature death, health spending, of course, access and affordability, and then kind of like this general caveat of quality of care, which looks at medical errors and the incidence of hospital-acquired conditions. And we consistently fail on many of these metrics as a nation. And it's certainly a very complex process and a complex system with lots of moving parts that come into play. But again, as I was preparing for this, one of the things that I came across was this cool, I guess you'd call it an editorial, from Harvard Health Publishing, from the Harvard Medical School. And it was published in July of 2021. And the editor-in-chief, you know, titles his little ed-op about, is our healthcare system broken? Talking about the United States. And he kind of asks a couple of different ways about it being broken. Is the healthcare system expensive, complicated, dysfunctional, or broken? And he says, well, basically, yes, to all of the above, that the health system is really damaged. And our experience with COVID has just exposed all of these evolving inequities, disparities, you know, the wrong emphasis on healthcare at large. And so despite, you know, globally, we have the highest cost per capita for healthcare. And yet, despite that, we have the poorest outcomes. We have poor outcomes on many key health measures. And those include like just general life expectancy, where we are actually declining, although we're up from where we were, I think like 20 years ago, we're still declining. When it compared to other industrialized countries. We have a high incidence of death related to preventable hospital admissions, high rate of death of suicide that's actually on the rise, incredibly bad outcomes with regard to maternal health and wellness, with a very high maternal mortality. The financial burden is crazy. And even though, you know, the ACA, the Affordable Care Act, is still active and that sort of thing, we still have a ridiculously inequitable distribution of health access to services. And a lot of that, this particular author relates back to how health insurance was, you know, kind of first offered in the post-World War II era as a way to kind of attract employers. And so that's kind of how health insurance got tied to employment. So if you're not employed, kind of up the creek without a paddle, as we know all of these things. But the reason why I'm sharing all of this information kind of as a foundation for the relevance of a trauma-informed approach is because of all of the things that impede equity, access, and optimizing health will find some roots in adversity, in disparity, in trauma, and other more human-created phenomenon, such as, you know, greed and misdirected investments in healthcare. For example, we have an incredible emphasis on technology and specialty care. And I'm not dissing technology or specialty care. Obviously, I'm in neonatology, a specialty care. But because of that, right, we don't put enough emphasis into preventative strategies, holistic strategies. And so when you come to a healthcare provider and you're thinking maybe they can give me some kind of a low cost treatment or intervention, a lot of those low cost treatments or interventions aren't covered by insurance. So they're less likely to prescribe these types of things because of that. So there's this really crazy way of looking at healthcare. We think about telehealth, right? And how as a consequence of COVID-19, telehealth has really flourished. But we weren't using telehealth because people couldn't figure out how to bill for it, how to be compensated for using telehealth. And so instead of trying to be creative and innovative, we've just kind of dug in and stuck with these strategies and approaches that are really becoming significantly antiquated. And again, coming across my research for preparing for this, there's lots of research now and surveys of the millennials and how they're coming through, and they're really demanding some more innovation, some more personalized care, more relationship-based care, which is absolutely brilliant because, to be honest, I think a lot of the folks that have been predecessors to this particular generation have really just kind of what can we do? It's just the way it is. And we've just accepted this, what I believe, substandard approach to our healthcare. Sorry, that just fell off, so we'll just be going without the headband. So we need some serious innovation. We really need some serious activism to really take on those systems that are preventing the natural evolution of healthcare and moving more towards a preventative strategy. Our current system is just going to continue to fail. We're going to continue to have declining life expectancy because we're not looking at things from a prevention perspective. People just see disease as a really awesome way of making money. I know I'm simplifying things, so take it at face value from a generalist perspective. That's what we're all about here, at least in the United States. I can't speak to other countries, but I think, if we could look at things a little bit differently, yeah, it's going to shift the flow of money. But, it's going to shift it, and we're going to have healthier people. Let's get with the program. But I also realized, did this editor of this, the author of this EdOp paper talked about some of the challenges that exist in changing the existing paradigm. There's lots of money being, funneled into what do you call them, lobbyists and those kinds of folks, well-funded lobbying groups ready to do battle. So we have to really get creative ourselves and take this on as a grassroots initiative to begin that transformation and transform the heart and soul of healthcare to really be responsive to the human needs, not the fiscal needs of those that are just kind of seeing this industry as a way to make some serious money. And so, kind of talking about that, what is quality healthcare? I mean, I kind of already said what it's not, right? So what is quality healthcare? What is it that is giving you the best service for your investment? And we've had some shifts, as I transition into the next section of this opening chapter. I introduced this concept of value-based healthcare, which we thought was going to really be like a panacea of transformation, moving from that, fee for service model to something that's really more, value-based. And the value focuses on improving patient health outcomes, and it is the measured improvement relative to the cost required to achieve the desired outcome. But what was interesting when I was actually preparing for this chapter was that all the big players really struggled to define what is value. And the more I dug into it, I realized that, yeah, there's a a subjective element to what is valuable to me versus what is valuable to you, right? And then of course the payers are really kind of driving a lot of these decisions, because what's valuable to them is to save as much money as possible. And so what one of the key authors that I referenced in the chapter, McCannon, did this really cool paper that highlighted 10 lessons from healthcare on quality improvements, which makes sense, right? We start looking, but of course you have to be looking at the right indicators, right? What are you trying to improve? If you're trying to improve efficiencies or, one aspect of the quality pie, right? Shorter length of stay, decreased morbidity, which morbidity, you just start dissecting it down. But quality improvement is a really great vehicle to help us uncover where are the gaps in the value that leads to the quality. And so I'm just going to kind of run through these, excuse me, these 10 lessons. One of them is to avoid systems myopia. And I like that they use that word because it really, for me, it's super visual, no pun intended. But being myopic, right? It refers to focusing on improvement in hospitals and specialty areas while failing to understand the larger picture, the larger societal factors. So I'll use neonatology as an example. So, avoid systems myopia, like in the NICU, if we're just focusing on discharge, the discharge date, then that's going to preclude us being aware of the quality of those outcomes, right? If we shorten their length of stay, but they're readmitted, within 30 days or beyond 30 days, following that discharge, how good of a job did we really do? So it's avoiding being myopic, really looking at the bigger picture is one lesson from quality improvement. Start with the customer, start with the patient, start with the baby and the family, in pediatrics, and find out what is it that you guys are looking for? What are your goals? And then, remember that model for evidence-based practice? It's not just doing what the research is saying, it's taking that and feeding it into this formula that also takes into consideration the clinician's values and what their experience and expertise is, but then the patient's values and their goals and objectives as well. So it's really, it's inviting us to be more integrated in our approach, despite the complexity. Life is messy by nature. So for us to try and clean it up, we're going to miss stuff if we don't really recognize and honor the integrated complexity of life and health and wellness as well. They talk about track rate of learning, study the rate at which new innovations are trialed to learn what works. And this continues to be a challenge, although I think I read recently that the gap between research and becoming mainstream practice had been 17 years, and a more recent paper said it's been cut back to 15 years, potato. I think we still have a huge gap that we need to address. And so, these kinds of impromptu series, right? The articles in review, other, people kind of doing podium presentations and it really getting that momentum for folks. I think the majority of our cultures are riddled with trauma exposure. And what we know from trauma exposure, one of the responses is an inability to change. We get so stuck in our way because to change means to be, it's naturally complex, it's naturally messy, it's naturally, unstable for a little bit of a period. And that for people that are already just so saturated with overwhelm, overwork, burnout, compassion fatigue, they don't have that capacity. So it's understanding these elements that are contributing to the inability for folks to adopt and transform practice to be more in line with current research and that sort of thing. So starting to, really evaluate that, do that self-reflection individually and, within your unit and even, within your system to better understand where the gaps are. Emphasize adaptation, not fidelity. Encourage and celebrate context-appropriate adjustments to evidence-based care, ideas and innovations. Again, it's shifting our understanding of how healthcare needs to be. It's not like, okay, it's this way for the next 30 years. Okay, everybody, you got that? It's not what it is at all. Life is all about constant change, right? We're always transforming, we're always changing, and we need to really embrace that reality into our systems as well. So the adoption of an adaptation to new practices, new innovations needs to be a process, a continuous learning process, and not just this is how we do it now kind of a thing. Number 5 is design measurement systems for the front line. We fail to do that a lot. The people in the C-suite, the bean counters and all those folks, they may have an understanding of what are the metrics, but on the front line, to me, it just feels like extra stuff that I have to do, and I don't even know why, just because somebody said I have to do it. And that can contribute to my dissatisfaction with my work, not feeling engaged, not feeling empowered. And so really, connecting the dots with the front line, and IHI talks a lot about this as well, but connecting the dots with the front line and figuring out, these are the metrics that we think are important. Do they make sense to you? And then no, oh, tweak, okay, great, and we do that, and then we define then what are we really measuring, and everybody becomes a stakeholder in the transformation. And this is what we've learned from quality improvement work. Embrace the nuance in evaluation. This is really great. So thoughtful researchers have come to understand that there are many approaches to learning and evaluation, and that each is appropriate at different times. So again, it's that relationship-driven learning model. You can get so far with a, a dictatorial approach to care. You can get so far, but the costs are exorbitant, and they're insidious, and you don't realize that you're getting, you're cultivating this disengagement and apathy with your staff when you approach learning and transformation that way. So really being respectful and engaging frontline clinicians. They definitely have a stake in the game, and they have brilliant innovations in their own right. So, understanding that, figuring out, how do people learn best? These are some best practices in learning that we can weave in and out. But it's not just because the words fell out of my mouth, this is how we're going to do it, and how I'm going to evaluate you. I'm sorry, we had that lecture, you didn't attend, and now I'm going to evaluate it. It's just silly. So understanding the nuances is really, really important. Live in the field. And this is something that I'm committed to doing this year. 2022 is getting more into the field now that I've not been at the bedside for a while. Live in the field and really appreciate, what are those struggles? What are those challenges? What are those joys and celebrations at that front line, so that I can better understand how I can serve those that are here to serve the vulnerable, to the families and the babies in crisis. Understand the psychology of change. It's not my way or the highway. If it is, you're going to be having some significant gaps. So really understand the psychology of change and create a process with input that can be repeatable, so that people, it's like a plug and play. Once you've created that process based on your understanding of the psychology of change and what works in your environment, right, then you can really get a higher adoption and a higher and better feedback as well. So this was, approach payment incentives with caution. And this is really talking about, how we tit for tat, like, okay, if you come, anybody who comes to the workshop today, I'm going to give you a Starbucks coffee card. Anybody who does this, I'm going to give you 5% here, and blah, 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 blah. And hey, who doesn't like a Starbucks card? But if it's, what do you call it? It's Pavlovian, then you're really undermining the professionalism of that individual, the integrity of that individual. I mean, once you know the culture that you're working in, you kind of realize this is as good as it's going to get, and I'm just going to try and find another place that places a higher value on my role and my contribution, versus just kind of nickel and diming people. Doctors and nurses are endlessly ranked and rated and compensated accordingly, but there's very, very little evidence to suggest that this leads to better outcomes. So, really think about how you are celebrating people, remunerating people for their work and that sort of thing. Really think about that and actually engage frontline clinicians. Look at best practices, because payment incentives can really be a slippery slope with a low yield. And then the final one is address inequity proactively. And I mean, we've had inequity in healthcare since its inception, okay? And so, and it's still a challenge, and we can't ignore it. And particularly now, I mean, it's becoming more and more in your face, which is the right thing. Major racial disparities in health and discrimination in the provision of healthcare services persists. And so organizations really need to address this open-heartedly, open-mindedly. We've got a group from UCSF Benioff, their NICU, have enrolled in the Trauma-Informed Professional Certificate Program, and they're all part of they started a DEI initiative. And so out there, and they're really kind of making some really great headways. They've shared some really cool grassroots strategies for engagement and to try and disarm people, and help people see that no one's pointing fingers here. We're all culpable for this, what's been created and what's been allowed to sustain for so long. And so we all have to work together to disassemble this systematic racism and the systematic disparities in healthcare. So address this proactively, lovingly and respectfully. And so I think these are great lessons from healthcare on quality improvement that can go a long way in helping us improve the quality and the value of the care that we provide to patients. When we're looking at more clinical outcomes, there was a really great paper by Teesberg in 2020, talked about defining and implementing value-based healthcare, a strategic strategic framework. And so they identified health outcome dimensions, and then I kind of extrapolated NICU examples, clinical examples within the NICU. So about capacity, these were the outcomes: capacity, and I'm sorry, I'm talking too fast. Healthcare, health outcome dimensions around capacity, the ability of the patients to do things that define them as individuals and enable them to be themselves. And so a clinical example is age-appropriate care. It's unrestricted nurturing time with parents. It's age-appropriate playful encounters. It's experiencing consistent, reliable relief of physical pain and stress. Unrestricted access to my family. So these are, when you're thinking about these quality metrics, it's important that you think about them with regard to each patient population. So health outcome dimensions have to match the population that you're serving. You can't just say, oh, it's this, well, babies, because babies are people too, right? And we have to meet their needs as well, their quality expectations, even though they're unable to articulate that. So I think, talking about a value-driven, and on Wednesday, I'll be presenting the value proposition of a trauma-informed paradigm. And so we'll touch a little bit more upon that concept again. But as I'm sharing this information with you, and again, I'm newbie here, so I want to co-create something that has value to you. Share your comments below. What are your thoughts? Have you read the book? Not that you have to, but have you read the book, and do you have your own ideas for innovations and that sort of thing? One section here that I did highlight that I wanted to share with you, when I'm talking about different populations, and specifically the newborn population, the unique shared needs of these patient populations, and I'm talking about infants, include being showered with love and attention, enjoying age-appropriate play, such as being read to, sung to, talked to, being held, cuddled, and kissed, enjoying pleasurable eating experiences and meal times, and having one's basic needs met, and living a pain and stress-free existence. So when we start talking about value-based healthcare and the implementation to achieve better patient outcomes, we need to be thinking about that holistically. The book really hinges on the shift of the biomedical framework, which asks the question, what's wrong with you, to the trauma-informed framework, which asks, what happened to you? And for the NICU, it's what is happening to you. We can use this framework as a prevention model aimed at improving the quality of this individual's experience that will then impact the quality of their life. And I hope that all makes sense to you guys as I'm kind of running through all of this for you. And again, ask me any questions. The other piece of this, kind of again, in setting the stage for the whole entire book, when I talk about quality care, is this idea of hospital-acquired conditions. Now, when I first came across this idea of hospital-acquired conditions, when I was, prepping for to write the book, I went on the Joint Commission website and the CMS website, and there's like insane laundry list, right, of hospital-acquired conditions. I mean, I think there were like this, I don't know, 7,000 entries, or at least 700. And I apologize for my inaccuracy, but it was crazy. It was a crazy, crazy big list of categories, if you will, of hospital-acquired conditions. And as I went through them all, again, newborns, people don't really pay a lot of attention to them in general, and I get it to a point, that, fix the disease and they're going to go on their merry way. But that was in the absence of really understanding what the impact is of early life adversity, of maternal separation, of unmanaged or undermanaged pain, of disrupted and fragmented sleep, of positional malformations and stressful and painful mealtime experiences, right? We didn't think about any of those things having an impact because we were focused on keeping them alive and getting them discharged. Two important things, but not exclusive to providing quality care. And so I started thinking about like some of the phenomena that the patients present with could really be construed as hospital-acquired conditions. Now, it's been a long time, and my physical therapy and occupational therapy colleagues can give me the latest and greatest about this, but I don't know if we see as much positional deformation and malformation as we saw during the early years of neonatology, in that late 80s or mid 80s to 90s, when we were seeing a lot of kids coming back to follow-up clinic with shoulder retractions, abduction in their leg orientation, abnormal gaits that were impacted because of the positional deformations they experienced during their NICU stay. Clearly, hospital-acquired conditions. Clearly, another phenomenon that was really kind of brought into full focus when I got the privilege of working with this really amazing group of clinicians in a NICU in Rocourt, Belgium. And this was when we had when I say we, my co-authors, the brilliant Dr. Sharon Gibbons, PhD, NNP, out of Canada, and the late Stephen Hoth, we had developed these core measures for developmental care. Well, then what we did was we put them together in this program and taught and did, PDSA methodology and stuff like that with this NICU to see, okay, if you adopt all of these core measures into your culture of care and how you deliver care to these fragile individuals, will there be an impact on your outcomes? And so what this group did was, like most countries, right, they have a national database of kind of like the key, outcome measures that you follow for premature people, right? Chronic lung disease or bronchopulmonary dysplasia, reflux, intraventricular hemorrhage, necrotizing enterocolitis, discharge with oxygen, and then a few follow-up things with regard to sleep and parent confidence and that sort of thing. And I don't have all of the data. You can find, I did report on that study in the first edition of Transformative Nursing in the NICU, but for that particular study, what was really intriguing, not just for us as the folks that delivered the program and did the education and facilitated and coached the transformation, but also the neonatologists that were in the unit, was a greater than 50% decrease in the incidence of reflux without any changes in the diagnostic criteria. And this was a core group of neonatologists throughout the entire study period, intervention period. It was the same folks, you know, and they had a very cohesive process for defining reflux, managing reflux, all that kind of stuff. But after the adoption of these core measures, that was one of the big things that they observed. And so it really got me thinking, is a lot of the reflux that we bear witness to in our NICU population actually a hospital-acquired condition? If you look at reflux in other patient populations, it's often associated with stress, distress, other types of GI disturbances that are mediated by exposure to early life adversity or adverse childhood experiences. Lots of the ongoing data from the ACE study links adversity in childhood to irritable bowel syndrome and other central sensitizing syndromes. And if you understand, you know, that the enteric central enteric nervous system axis, you can kind of start to think about these things. And that's what we need in neonatology and healthcare at large, to really kind of look at these things. Yes, I was a nurse practitioner. It's a super nuisance, right? Reflux, you'd be like, oh man, what are we going to do? Because when you look at the interventions, it's 6 of one, half a dozen of another, and they don't impact the patient positively in any way, shape, or form. But if in fact the intervention is actually promoting more parental proximity, more skin to skin care, more consistent pain management, a more consistent physical environment that's less overstimulating, protecting sleep, right? You're minimizing the adverse stress that they're experiencing, and consequently seeing a reduction in reflux. You know, I mean, gee willikers, yeah, it's a hospital-acquired condition. And yes, we should replicate this, you know, experience that the hospital in Rocor had, replicate that again. But we need to start really understanding not just the symptoms and managing the symptoms, but what's underlying the symptoms. That's quality healthcare. That's value-driven healthcare. That's patient-centered or patient-centric healthcare. And so, you know, that will lead us to reducing these hospital-acquired conditions. And the reason why it's a big to-do with the Joint Commission and CMS is because they cost an arm and a leg, right? Hospital-acquired conditions add additional costs to the patient's stay that insurers don't really want to pay. And so we need to really figure, and I don't really care about insurance companies, but, you know, the intention is to deliver high quality and to mitigate and manage these experiences that can be preventable. And that's why, you know, at least for me and my team, understanding how early childhood adversity impacts us physiologically, psychologically, sociologically, adopting this paradigm at the beginning of life, your first hospital experience, can actually be a preventative strategy. But it has to be clearly articulated, clearly delineated, clearly measured, and that sort of thing. And as I summarize my chapter here, this first chapter, nurses play a key role globally in building evidence and working with interdisciplinary teams to accelerate the implementation of evidence-based nursing practice. This, again, you know, we need to get back to our roots as nurses, and we need to help our colleagues, our interdisciplinary colleagues, to really understand how you are trying to orchestrate, right, the care that is being delivered, not just focused on their medical or surgical needs, but what are their human needs? As I mentioned before, what are the basic needs of a newborn? To be loved and cuddled and kissed and sung to and talked to and not know pain and fear and all that kind of stuff, because all of those experiences impact how the brain's going to be wired, right? Neurons that fire together, wire together. And the definition of trauma is an event, a series of events or circumstances that are experienced by the individual as life-threatening, right? As dangerous or life-threatening, either physically or emotionally. And that, my friends, has lasting adverse consequences on the individual's developmental trajectory. And that's really what we're talking about here. It's understanding the relevance. This idea of trauma-informed care isn't just another fly-by-night thing that it'll die down, just like developmental care, kind of waxes and wanes, and some people do it, and some people wait until they're stable when they're stable to get developmental care. I think we're seeing less of that for sure, but we need to understand the connection between the practice that we're adopting, right? These paradigms that we're adopting, understand the connection with the larger view, the bigger picture, that providing trauma-informed developmentally supportive care, at its core, it improves outcomes, it improves experiences at the very least. And that is a quality indicator that brings value to the infant, to the family, to the clinician, who doesn't want to be causing trauma, who wants to facilitate the best experience in the most difficult of circumstances, right? How can I make this less traumatizing? Give me some strategies. Here you go. Yes, this is what we're going to do. And start really recording what is the impact of this paradigm on short and long-term outcomes for patients, for their families, for the clinicians. And then you can spin that from the clinicians up to the hospital, the systems, the states, the nations, and then the world. And so, this is a lot of work. It's a process, but it's what we have to do. And so at the end of each chapter, I tried to find a quote that felt appropriate for that section. So I'm going to just read you the quote from the end of the first chapter. Empowerment at the end of the day comes from refocusing healthcare from the conventional question of what is the matter with you to the modern question of what matters to you. From what is the matter with you to what matters to you. And that's DeGloria Clayton and Gia Russo. So I hope you found this valuable and interesting. I'm going to also pop down the name of the book, the publisher information, and the publisher is actually granting the 25% discount if you want to buy the book with the code that I'll put in the video description as well. Please hit me up with your questions, and tomorrow, January 4th, we will be talking about the neuroscientific consequences of NICU trauma. So I hope to see you then. Take care and care well. Bye.